Good morning. My job is to provoke you, hopefully inspire you, and get done on time. So despite my southern drawl and our penchant to drag out our sentences, I'll try to accomplish those tasks. Before I begin, it's important anytime you have an outside speaker that there be disclosures. Many of you probably only think of RAND in terms of Dr. Strangelove and national security, but in fact, RAND also does very important work in the healthcare, public health, and healthcare delivery space. We are a nonprofit, non-governmental, and strictly nonpartisan organization dedicated to improving policymaking through objective research and analysis. For many years, I was at Emory University in Atlanta, and someday I'll actually get an appointment at UCLA, but I am nominally a visiting professor, and so those are my academic affiliations, and otherwise I have no conflicts to disclose. Before I begin, I do want to recognize a great giant in health policy and health systems improvement for the last 40 years, and that's Larry Lewin. I was crashing your fellows' reception last night and enjoying that wonderful wine when my email flashed the message that Larry Lewin has died. And many of you know Larry founded the Lewin Group, did an amazing string of hard-hitting analysis on a variety of topics in American healthcare, and was a central figure in the IOM's work on many committees. He and I actually bookended major work on the consequences of uninsurance in the United States in the first decade of this century. And one of his last papers I was fortunate to co-author with him. So, Larry, this one's for you. Larry was a mentor. Donna was an inspiration. I met Donna briefly about 25 years ago when she was wheeled into my ER at the Regional Medical Center at Memphis. Only 35, it just took a glance to tell me she was critically ill. She was comatose, she was posturing, her blood pressure was about 250 over 140 diastolic. I didn't need a CT scan, although we got one to tell me what was going on. But before we scanned her, we intubated her, we started nitroprusside, we did all of the advanced resuscitation techniques we knew then and now, and her scan showed what I suspected. She had a massive intracerebral bleed. Despite our best efforts, despite a full court press, despite everything we knew then to do for a hemorrhagic stroke, within 2 hours she was dead. I went out to the family room to break the news to her sisters, and I started to tell them what had happened, and one of her sisters said, "We told her this was going to happen." I said, "What do you mean?" She goes, "Our sister had terrible high blood pressure. She took 3 medicines for it. But about 6 weeks ago, she lost her job. And with it, she lost her health insurance. And she wasn't making that much money to begin with. And about 10 days ago, she told me, 'Betty, I don't have much money, and these medicines are expensive, and I got to feed my kids.' And we said, 'Don't do it, Donna, don't do it. You got to take that medicine to stay healthy.' But she bought groceries instead. Because this woman was forced to make that choice, and she did what any mother in this room would do. She put her children's interests ahead of her own. She paid for that decision with her life. She was lost to the workforce of Memphis, no longer paying taxes, no longer earning a living, and most important, no longer raising her 3 children, who then had to turn to other people for support. The absurdity of this story, of course, is that we spent more money in an absolutely futile effort to save her life over roughly 3 hours than would have required keeping her in her hypertensive medicine for the rest of her life. And yet, we continue to make those value judgments in this country every day since to the current time. Now, it's political season, so you can expect to hear politicians loudly and proudly declare that we have the finest healthcare system on earth. That may be debated, but one thing can't be debated: we certainly have the most expensive. We spend more money in absolute terms, some $2.6 trillion per year, more money per person and more money as a percentage of GDP than any nation on earth. And worse than that, at our current rates of growth, even for allowing for the so-called encouraging flattening in the last 18 or 24 months, we're pulling away from the pack. 25 years ago, we were clustered with Western Europe. Today, we've opened a lot of daylight between their spending and ours. And that's had a real impact on American business, your clients as well as their employees. Business contributions to employee-sponsored health insurance, still the bedrock of coverage for the under 65 age crowd in this country, doubled over the last 10 years. So did the co-pays and deductibles and out-of-pocket expenses of American families. So this has been a tremendous drag on our economy, on America's businesses' ability to compete on a global stage, and on workers' ability to get on with the rest of their lives. But the fact is, most Americans, their eyes glaze over at the idea of 2.6 trillion. It's an million, billion, you know, this all sounds about the same. It's hard to get your mind around a number that big. So last year, a colleague of mine at Rand and I went at this and we said, okay, Americans understand when they pull up to the pump, especially in Southern California, trust me, how much they're spending for gasoline. And when they go up for some fast food, they know how much they're paying for a burger. I purposely picked that awful picture just to inspire all of you with your diets. But they don't really know how much they're paying for health care. And that's because a lot of what they're paying is invisible. It's out of view. It's underwater. And so we did a study to take that figure of 2.6 trillion and a decade of cost growth and said, what did this mean for a typical median income American family lucky enough to have employer-sponsored health insurance? So we tried to take it down to the family level and help a family understand what economic impact did 10 years of cost growth in the American healthcare system have on their bottom line. Well, the first thing we pointed out were that families see their premium payments and their out-of-pocket spending. In 1999, they paid about $85 a month for their insurance premium and $135 a month out of pocket, pharmacy, etc. But they didn't see the largest amount of their health care spending because it was underwater. They didn't see the employer's contribution, which, as we know, isn't really a contribution. It's the wages they otherwise would have gotten, but instead are used with tax benefits to purchase their health insurance. They certainly didn't perceive that a large chunk of their taxes, state and federal, went to fund Medicare, Medicaid, health departments, and other aspects of government-funded health care. In just 10 years, both these visible and invisible expenditures have grown and grown dramatically. Families' insurance premiums more than doubled in 10 years. So did out-of-pocket spending. The employer insurance premium also more than doubled. And taxes for health care also grew dramatically, but not as dramatically, not because public programs weren't getting more expensive, but y'all remember something really interesting about 1999? Any political scientists in the room? We had a budget deficit, now a budget surplus. We were paying down the national debt. But in 2009, we were taking in $6 and spending $10 at the federal level. So if you factor in deficit spending, deferred payments to later, again, you see this more than doubling of cost. And for that family, that final chunk of money was going towards their kids' and grandkids' burden, not their own in that particular year. Translating this into numbers for our family, in that 10 years, the median income family that we studied had an income gain of almost $23,000 a year. Inflation took a big bite out of it. So did increases in non-health care taxes. But health care spending took $7,380 out of their earnings, just the increase in health care spending, not their total bill. In monthly terms, that meant about an extra $95 a month towards their bottom line after 10 years of hard work and climbing the economic ladder. But in fact, if you factored in the deficit spending, that adding to our national debt, that family actually lost ground, nearly $300 a month, entirely due to rising costs of health care. Now, what if you and I together had somehow managed to limit growth of American healthcare spending to GDP plus 1%? That's the current target for the Affordable Care Act. That is about what Western Europe managed during the same time period. What if we had done that well? What if we had managed to cap growth so it was still outgrowing the economy, but not as fast? Well, our typical American family would have had another $335 a month to spend on other priorities. What if we doubled down and actually had managed through some amazing feat of magic, maybe Disney magic, that we had limited healthcare growth to the inflation rate, the consumer price index? Well, if we had done that, that family would have had $545 a month to spend on other priorities in 2009. Annualizing that out, in 2009 alone, that would have been an extra $5,400 of money in their pockets to spend on other things. Now let's make that even more concrete. What would $5,400 have allowed our family to do? Well, they could have made 2 extra mortgage payments. That might have kept them in their house. They could have enrolled for a year of full-time community college. Maybe they could have picked up different skills to been able to get a better job to contribute to our economy. They could have paid for 4.5 months of child care for a 4-year-old so the spouse could have gone to work and contributed to the family's income. Or they could have paid down a good chunk of our massive credit card debt. But none of this happened. Instead, the American healthcare system ate it. Now, what did all that extra spending buy? Well, compared to 10 years earlier, we got 10% more office and same-day hospital visits. Wow. We got the same number of overnight hospital stays. We got a lot more MRI scans and twice the use of CT scanning in 10 years without obvious gains or benefit in health, but a heck of a lot of additional radiation. And in fairness, our adult life expectancy improved about a year on average. But before you celebrate too much, those other competing economies, their population's life expectancy grew about twice as much as ours did during the same time frame. So are we getting our money's worth? After all, that's what we're all about, right? Well, obviously, no. In 2003, Beth McGlynn and colleagues at RAND did a now landmark study to measure the quality of U.S. healthcare in selected communities around the country. And they used a very objective chart audit approach to see whether Americans were getting recommended care, things consistently we ought to do when we see people in the doctor's office, preventive care, acute care, etc. The bottom line of this study was that American adults get currently recommended care about 55% of the time. That's it. For all that money, and we're only getting the care we should be getting 55% of the time. And the fact of the matter was, those of you in Boston who say, yeah, well, in Boston we know how to do everything better than the rest of the country. No, you don't. You didn't do any better than the other comparison cities. Whether it was measured in overall performance, preventive care, acute care, or chronic disease care, everybody scored a C- at best. But hey, it is election years after all. We're still #1, right? Well, not exactly. Let's pick one objective measure. A country's healthcare system ought to keep people from dying prematurely of medical conditions that we know how to treat today. Heart failure, bacterial pneumonia, diabetes. Now, we've all got to die of something someday, but dying early from a readily treatable chronic disease is a pretty objective measure of how well a health system performs. And this study done by Ellen Nolte of RAND Europe and colleagues, they compared deaths from treatable conditions in 16 high-income Western-style democracies. Now, the keen observers in the room will say, wait a minute, there's only 15 bars on the chart. Oh, you're right. We forgot the United States. 16th out of 16, dead last. Part of the reason we don't do as well compared to some of our competitors is because 50 million of our fellow Americans don't have health insurance. And studies have shown, and I co-chaired an AOM committee in the early 2000s that showed that uninsured Americans get about half the medical care the rest of us get, and they tend to get it too late, and they pay a terrible price. And even before the onset of the Great Recession, the rate of uninsured non-elderly adults in the U.S. rose from 17 to 20%. These folks are largely shut out of the American healthcare system, or when they get in very late in the game. So where do the uninsured, the underinsured, and the rest of us go for treatment when we get sick, when we don't feel good, or when our chronic disease is getting out of control? The AccuChecks are going over 300. We're getting tightness in our chest from asthma. Where do we go for care? Well, a study that I did with colleagues at Emory and Mathematica about 18 months ago, we looked at this. We started by saying, where do doctors practice in America today? Well, about 4%, that toenail, practice in ERs, the background that I came from. About a third, not nearly enough, practice primary care. It ought to be more like 50-50 with a third group, specialists. But currently, they're about 2/3 of America's doctors. Follow the red. The next bar shows where Americans overall go when they get sick or have an exacerbation of their chronic disease. 28% end up in the ER. Another chunk end up seeing their specialist. If it's an eye problem, they run straight to the ophthalmologist. If it's a skin problem, they run straight to the dermatologist, etc. And the rest, the majority, see their primary care doc, but less than half the time do they go to primary care. But if you look at Medicaid and CHIP patients, half of them end up in the ER, in part because the reimbursement is so poor, primary care docs don't really want to see them. And if you're uninsured, the odds are you'll get your acute care in an ER 2 times out of 3. And that practice has had an immense consequence on our nation's emergency care system, in crowding, in boarding. Most hospitals today, unfortunately, view their ER as a loss leader. They tend to back patients up down there. The busier it is, the less likely the riffraff will find their way in the door, and they're typically the last patients who get admitted to the hospital, even if they're often the sickest, insured or uninsured. So, if we're only providing recommended care 55% of the time, and too many Americans have to turn to the ER for care, so is the answer more medical care? No, absolutely not. In fact, we're burning money hand over fist. The IOM, a blue chip panel, estimated the U.S. healthcare system wastes $750 billion per year on unnecessary or inefficient services, excessive administrative costs, high prices, medical fraud, and missed opportunities for prevention. Now, the RAND work done by Bob Brook that looked at appropriateness of care came up with a similar figure. You can compare our spending to Western Europe, you get a similar figure. You can compare low spending communities in the U.S. to high spending communities in the U.S. and you'll get a similar figure. So it is probably somewhere between $600 and $800 billion a year that we're just flat wasting because we're not approaching the game correctly. And the fact of the matter is, we do what we do because the system today is engineered to deliver that result. Patients assume that if it's more expensive, it's got to be better. After all, in America, price is a proxy for quality and hardwired into America's minds. And besides, my doctor knows best even when they don't, or even when they have an obvious incentive to sell me all the health care I can afford, whether or not I need it, rather than providing me with the health care I need, whether or not I can afford it. For doctors, hey, as long as fee for service is the top rule, the more I do, the more tests I order, the more treatments I administer, the more money I make, the greater I can upcode the encounter. And furthermore, if I don't do that, if I skip the test, if I go talk to a family in the ER at 2 a.m. about whether or not we should intubate and start advanced life support on somebody who's clearly at the end of a very difficult chronic disease, I won't get reimbursed for that. I raise the possibility that Uncle Bubba from Birmingham will roll into town on his Harley and sue me for having not intubated the patient. It's a very difficult dilemma for American doctors. Hospitals have a goal. It's to fill every bed, but not every bed with a patient, every bed with a pre-screened, pre-approved, financially qualified elective admission for an artificial joint or a cardiac cath. That's where the money is. And vendors understand that newer products fetch higher prices, and if you push back, or your company push back, or your health plan push back, we'll just find a poster child to scream to a member of Congress or to the local paper, and we'll make you pay. That's really how the system works today. It has no brakes, and nobody is dealing with the underlying problem, which is rising costs. Now, there are 4 basic ways to reduce costs. 3 of these were recently summarized by Peter Orszag. You may remember Mr. Orszag, very bright health economist, was the director of the Congressional Budget Office for a number of years, and then he went on to be President Obama's first director of the Office of Management and Budget. He wrote an essay that basically said, will health care save or ruin the United States? Something to that effect. He identified 3 of these strategies, but he missed the 4th. The first 2 basic ways are basically bad ideas. We can simply provide less care through blunt rationing. And that's actually the approach that has been the dominant model in the U.S. for the past 50 years, except we ration based on ability to pay, not based on need or potential benefit or anything else. That's where the uninsured are looking in while everybody else is getting a ton of stuff done to them or for them. We could try another approach, which is kind of what Medicare and Medicaid have done for the last 20 or 25 years, is which we can just basically expect you get the same care, but we'll pay less for it. Doctors are canny types. My colleagues are really good. You cut reimbursement to neurosurgeons for back surgery, what are they going to do? They're going to operate on more backs. And when they do that, you have the hospital fee, the anesthesiologist fee, the extra medications, the pain meds post-op, etc. And so when we try to squeeze doctors' reimbursement on a case-by-case basis, many doctors respond by upping their volume and reaching into populations who are more marginal in terms of indications. It doesn't work very well, and it triggers a lot of extra spending. The third approach is the one that we are currently focusing a lot of our time and effort on. It looks more promising, and that is to eliminate wasteful care, that $750 billion target of opportunity. But again, it's pretty challenging. One way is to encourage patients to think more like consumers by giving them, to use a political phrase, skin in the game with higher co-pays and deductibles. And the other approach is to encourage providers to choose more selectively and wisely what the patient needs by paying for value rather than for volume. Well, what do we know about the effectiveness of these 2 strategies? Well, recently RAND conducted the first comprehensive study of the impact of high deductible health plans. It's been published, but a summary article will be coming out in next month's Health Affairs, and I commend it to your attention. We worked with 60 large employers, half of whom offered HDHPs, high deductible health plans, among the opportunities for their employees to select. There were a variety of benefit designs examined and a variety of copay levels looked at. They followed these folks for over 5 years, millions of covered lives. This was a natural experiment, but a very rigorous one. And they compared cost growth in the first year that families shifted from a traditional plan into a high deductible health plan compared to families who stayed put. And this was funded by RWJ and the California Healthcare Foundation. Well, first of all, they found that high deductible health plans did reduce spending across the board, but most of the benefit, if reduced spending is your target benefit, was not in the more modest deductibles, but in really high deductibles, $1,000 per person in the family or more. There, the reduction in spending was almost 20%. That is an impressive bite out of the apple. They found evidence that patients are acting more like consumers. About 2/3 of the reduced spending came from people having less, quote-unquote, episodes of care, i.e. trips to the doctor, visits to the nurse, things of a various sort that involve interacting with healthcare providers. But a third of the reduction came from actually making different choices when you were with your doctor, or when you were in the ER, or when you were engaged with a nurse practitioner or a PA. High-deductible health plan patients used fewer services per episode of care. They opted for brand-name drugs less often. They made fewer visits to specialists. And they significantly reduced their rate of hospitalizations, largely for elective procedures. They were thinking that their money is now involved rather than the plan's money or the company's money. But there were also some worrisome trends that really we're going to need to follow up over a longer period of time. There was evidence of worrisome reductions in high-value care, monitoring of glucose levels in diabetics, lipid profiles, cervical cancer screening, mammograms, colorectal screens. And ironically, in these plans, these are covered services with first dollar coverage, suggesting either that the plans didn't do a good enough job of educating patients about what the plan covered or didn't cover, or they just didn't go to the doctor at all that year, so the doctor wasn't able to badger them about it's time for your mammogram or time for your colonoscopy. So clearly we need to follow these folks for more years to make sure that the cost savings are effective and useful, and we're not skimping on really necessary care that will come back and bite us or the family who's making these purchasing decisions in future years. We're also today at RAND looking at different strategies to motivate providers to be more responsible or more prudent. Will pay-for-performance work? Well, the effects to date are mixed. There is some evidence that physicians are moving in the right direction, but other evidence that P4P only results in sort of knee-jerk Pavlovian behavior for the particular performance measure without broadly affecting quality and outcomes. Bundled payments, they're conceptually promising, but the early generations are quite complicated. Implementation is behind schedule, and it's really too early to say whether they're going to make a difference or not. How about public reporting of prices and quality? Well, these efforts seem to do more to motivate providers like hospitals to behave than educate and motivate consumers to make different choices. And one of the most interesting and troubling observations about price transparency is, guess what the public does when they go on the web and figure out that their primary care doc charges less than another primary care doc? They go to the more expensive doc. Because, quality is more expensive. And so we're still hardwired to think that if it costs more, it must be better. If the drug is more expensive. In fact, there was a wonderful study done a few years ago that took a standard pain pill, and instead of placebo control, everybody got the same pill, but half the patients were told it cost 10 times as much. Guess which group had better pain control? Boy, is this hardwired in the American psyche. So until we can match cost and good, reliable measures of quality, we may find that quote-unquote cost transparency hurts us instead of helps us, unless the patient has substantial skin in the game. And finally, what about medical homes? Another great idea, highly promising, too early to tell, but we're very involved, as are other groups, in evaluating these across multiple dimensions. But there's a fourth approach. And this is the approach that ACOEM members have championed and demonstrated value probably more effectively than any group in American medicine, and that's the value of prevention. Targeted programs to discourage and lower rates of smoking, deal with obesity and other chronic contributors to bad health, and employee wellness programs and occupational safety programs. You've generated the data and the information on the power of this approach, and yet it's amazing that this is not getting talked about in Washington. And in fact, under even a little bit of fiscal pressure, what's the first thing that Congress wants to throw out the door? Prevention programs. How stupid is that? But that's where the dialogue is. In fact, even a guy as bright as Peter Orszag, in his essay about controlling American healthcare costs, didn't mention this as a strategy. He talked about the first three. He didn't write about this one. But it works. I purposely put in this chart showing an unbelievable decline in deaths and injuries from motor vehicle crashes for two reasons. One, because it's one of the most powerful examples of the power and impact of prevention. And this was prevention at a policy level across populations. It wasn't just buckle up programs in the workplace or wear your seatbelt when you're driving your forklift. This was a broad population-based intervention that has had dramatic impact on injuries. And as many of you know, injuries are still overlooked in many occupational settings, not so much at the workplace, but in the other parts of the week when the family is not at work or the breadwinners are not on the line. And injuries are second only to upper respiratory infections as a cause of doctor's visits and second only to childbirth as a cause of hospitalizations. And boy, can we make an impact, and we have. One of my favorite anecdotes, in Georgia for many years, a lobbyist for the state's children's hospitals and I were a two-man wrecking crew that every session of the Georgia General Assembly, we joined forces to defeat efforts to repeal Georgia's motorcycle helmet law. I saved more lives every year that I did that than all of my shifts in the ER. But one year it looked like the biker lobby was going to really roll us. And it was not going in our favor. And we got allies from a very unexpected quarter that has a powerful hold on the Georgia General Assembly, and it was the commanders of Georgia's many military bases. And they wrote a joint letter to the General Assembly and said, please don't do this. Because if you repeal this bill, our soldiers, our sailors, our Marines will die on Georgia's roadways, and we need them to protect the country. And that made a decisive difference. So employers have a powerful voice in the political process as well as in the workplace. Obesity is the immediate challenge, and boy, is it going to be tough. It is not as clean cut as smoking. It is not as amenable to policy options as motor vehicle crashes, but it is real, and we have seen explosive growth in obesity rates in this country, especially morbid obesity, the most severe levels of obesity. And left unchecked, it will eat us alive in terms of costs and outcomes from diabetes, coronary artery disease, and many other health problems. So we have got to get a handle on this. We do know that the local environment and food prices and the differential pricing of foods makes a big influence on what people choose to eat and how much. And research ran by a colleague named Roland Stern has shown that eating less junk food is a far more powerful lever than eating more fruit and veggies. Not that fruit and veggies aren't good for you, but the real driver is very high-calorie drinks and other food products that really, and it doesn't take but a few hundred calories a day, and bam, you're there. Finally, there's a lot of buzz about the idea of opening supermarkets in food deserts. That's a trendy term for communities that have nothing but junk food or liquor stores available, or opening more green space so people can get out and exercise. It might be a good idea, but we don't know yet. And with the help of the National Institutes of Health, colleagues of mine at RAND are doing some of the most rigorous controlled studies of both strategies, so we'll have a better idea of whether this works or not. But what can you do beyond what you're already doing today? Well, you in this organization and working with the companies and the employers and the various people that you engage with, you're perfectly positioned to do three things. First, you can encourage your companies to give their employees more skin in the game. Encourage them to look at the data on copays and deductibles, but match it with the tools employees need to make smart choices. Not just prices, but prices and quality information. And trust me, the healthcare industry really doesn't want to give that data up, and they've got to if we're going to get where we need to go. Second, as many of you are already doing, stop worrying so much about individual episodes of care and focus on improving delivery systems and disease management, including prevention programs, to improve the health of populations, not just the population of your company, but the population, the community in which your company functions, because it'll have spillover effects that are positive for improving the community, but also as the community's health is better, your workers' health will be better as well. Think about the story about motorcycle helmets. And third, educate your company's leadership and the public to insist that provider payments shift from fee-for-service. We will never solve this problem if we stay in the fee-for-service world, to rewarding for better outcomes and creation of healthcare value. And you've got to do all three of these at the same time. One at a time won't work. So the key for the future really is to realign the healthcare system towards creating value rather than just running the meter. For patients, they need to look at this as it's my money. I'm going to use it wisely, and I'm in charge because it's my health. Being a passive recipient of advice won't cut it in the future. We need to be more discriminating customers. For physicians, they need to understand that the better I do, the more money I make. If the reward for being innovative and cost-efficient in delivering high-value care is a cut in your income, we will not get America's doctors to go along, and America's doctors still control the vast majority of healthcare spending through their ordering, their admitting, their surgery. And second, doctors need to understand the future, that the safer I am, the less risks I take. And there are risks associated with doing too much as well as too little. Hospitals need to get that safety sells. The auto industry finally realized that after fighting tooth and nail. Imagine what will happen when the hospital industry realizes this. And that greater efficiency means higher earnings rather than growing revenue faster than inflation year after year after year. And when vendors realize that creating products that actually improve value generates bigger profits than simply creating a new product, pricing it 5 times higher and forcing you to pay for it, we'll see real ingenuity among device and drug manufacturers. The United States of America has the most efficient agriculture sector on the planet. We have, by most accounts, one of, if not the most efficient manufacturing sector today. American workers are incredibly productive. We have very efficient information technology and communication systems in most sectors of our economy. And we have an appallingly inefficient and all too often ineffective healthcare system. Now, the same people, the same society, the same can-do entrepreneurial spirit that created those first 3 sectors is creating the 4th. So I don't think it's because we don't know how to do better medicine. I don't think the fact that we're 16th out of 16 in amenable mortality is because we don't care. I just think that our incentives and our awards are badly misaligned and are reinforcing non-productive, non-efficient activity. So you, ladies and gentlemen, you have an amazing bully pulpit. Shout from the rooftops that we can have a better, more highly efficient, more high-performing healthcare system that delivers better health and costs less. Shout it from the rooftops, shout it in the boardrooms, shout it in your clinic, shout it in your neighborhoods and in your communities, because you folks get it better than any other group in American healthcare today. And I think you're better positioned than any other group to spread that message through your employers, through your communities, with your patients, with your families. And by doing that, we can and we must develop the healthcare system that our citizens need and our country must have if we are to prosper in the 21st century. So good luck to you at this meeting. Share ideas, share your energy, challenge one another, make a difference. Thank you very much.